Thank you so much. As Valeria said, I'm Luis Taveras. I'm one of the trauma critical care fellows here at UT Southwestern Parkland. And I want to thank you all for joining. Calling you from Dallas, Texas. I want to thank you for the opportunity to present this case and thank my mentor, Dr. Dumas, for his guidance in presenting this case. So this is going to be a case of acute liver failure after blunt trauma. And this patient initially presented after a motorcycle crash. He fell off his motorcycle and landed on dirt. And then another motorcycle landed on the patient's back. The patient's neck brace and helmet was broken during this incident. He arrived to a level 4 trauma center. So that's the lowest category within the American College of Surgeons trauma system. And his vitals on arrival were a pulse of 113, blood pressure of 118/79, respiratory rate of 38, and satting 98%. He had a C-collar in place, his airway was clear, he had bilateral breath sounds, there was no external signs of hemorrhage, and his GCS was 14, accounting for some confusion. He was somnolent but interactive. He was somewhat pale in appearance as he was described, and he was in significant pain. There was some abdominal tenderness, there was some guarding and rebound, and his HemoQ was 8.9. So patient had IVs placed and started IV fluids, and initially resuscitated to take him to the CT scanner. So they had CT scan capabilities, and these are some of the images that they had. So this is one slide in which you can see some representative actual cuts, and you can see significant devascularization on this area of the liver here, with maybe some contrast on the outside here. This other cuts, you can start seeing some areas of very heterogeneous contrast within the hilum of the liver. And once again, you can see the clear devascularization of the left side of the liver here. Now, within this image, you start seeing more active disruption around the porta hepatis with active arterial extravasation. And then it was reported as injured hepatic artery, and there was other areas in the abdomen which you can see some pooling of contrast. Here you can see more clearly some fluid, likely blood around the liver, and then some contrast layering on the lateral portion of the liver. And then this is a similar image showing about the same. We can see a lot more contrast around the liver. So with these images, I think we have our first point of discussion. What happens next to this patient? Is this a patient that should go to the operating room, to interventional radiology? This is someone that we will be observing. What do the panelists think should be the next step for this patient?
Thank you, Dr. Taveras. Dr. Ochman, your comments, please.
Well, it would all depend on the hemodynamic stability of the patient. If the patient is hemodynamically unstable, probably have to go to the OR for to assess the situation in the OR, which most likely would lead to, if it's any obvious bleeding from the hepatic artery that can be controlled surgically, will be controlled, otherwise the liver will be packed, and from there go to IR. So we will probably do this case in the hybrid room and have an IR come in. If the patient is hemodynamically stable, his active bleeding from the liver, he needs to go to IR for angioembolization, which will also give us a better description of the anatomy. My feeling is that if he is not hemodynamically unstable, he is close to be, because of the significant hypoperfusion of the left lobe of the liver. That will indicate a significant vasoconstriction with decrease of flow in the portal vein, unless the portal vein is damaged too, which I don't think so, because he will have more bleeding, but it's possible. So again, summary, dynamically unstable or more or less stable or metastable IR, ideally both procedures done in the hybrid room to be able to switch from one to the other. Thank you.
Thank you, Dr. Ochman. Dr. Supa, Bangkok.
I agree with Dr. Hoffman's suggestion. If this patient's hemodynamic is stable enough, I think he should go to IR. Number one, to try to embolize the bleeding vessel. And number two, to try to study the anatomy of the hepatic artery. Because it looks like that this patient has a left hepatic artery injury. And he has a significant liver ischemia that we can see. So I think if possible, IR may be able to try to reperfuse the left lobe liver. I have never seen this before, but I think theoretically it's possible. Thank you.
Thank you, Dr. Supa. Dr. Antrak, would you like to comment? I don't think we have Dr. Antrak. Thank you. Any other comments or questions from the panelists? Okay, Dr. Taveras, we go back to you.
All right, so to give a little bit more information, this is a level 4 trauma center, which was about 25 miles from the nearest level 1, being that the highest level of care within the trauma system. And this was around 1 p.m. Patient got about 5 units of RBCs. The hospital did not actually have capabilities of MTP. They did have transfusion services, but not necessarily massive transfusion protocol. They did have interventional radiology available, and although they did have an operating room, they also had interventional radiology. So now that we know this, does this change management at all, or are we still having the same management pathway that we had proposed?
Dr. Supa?
I think with IR capability, this hospital should be able to perform angiography embolization. But with limited resource of blood transfusion, maybe it's safer to transfer to your hospital, to the bigger trauma center, if the hemodynamic of the patient and time permit. Thank you.
Thank you, Dr. Supa. Dr. Ochman?
Well, I don't know what the situation is in Texas. I was in North Carolina for a while, and we were getting patients transferred for sometimes significant distance. But one of the things I remember there that used to happen that I would get the phone call from the hospital requesting the transfer, and I could really assess, talking to the person on the other side of the line, that they couldn't handle anything. Even things that is kind of like the very basics. So yes, we can get into an argument. Yeah, this patient is actively bleeding. The transfer is too long. You should do something there. But sometimes that argument doesn't get you anywhere. And I think if it's possible, I would transfer this patient to a trauma center where you have all the resources and the expertise to deal with this. Again, it's difficult to say. It depends on the resources that you have in that area, depends how easy it is to communicate in the same medical language to the physician on the other side of the line. It's a tough call. So yeah, ideally it should be embolized where the patient is, but you might not have somebody able to do that over there. Thank you.
Thank you, Dr. Ochman. Dr. Taveras, we go back to you.
Yeah, I think Dr. Hochman makes a very, I'm not muted, am I?
No, you're here.
No.
I
Okay,
should see
great.
Dr. Machado also showing. Do you have any comment, Dr. Machado?
Yeah, I anticipate that this patient will require not only IR, but then significant resources from the ICU's perspective, transfusion requirement for correction of the coagulopathy. So it's better to have him in a system where you can do ROTEM and TAG to direct your correction If IR, yes, it's important to address the active issue, but then in anticipation to further needs, I think that it is most appropriate to be in a system where you can have the ICU capability as well as the blood bank that can support this patient, because I anticipate that his liver is going to fail and therefore he's going to have a significant coagulopathy and transfusion requirement. Thank you.
Thank you, Dr. Machado. Dr. Taveras, yes, we go back to you.
Good. With that said, this patient ended up going to the interventional radiology suite about an hour and 20 minutes after presentation. And I have a few of the images that were obtained from the radiology suite. We can see this mesenteric angiogram. The spleen looks fine. There's no issues with the celiac trunk, but we can start seeing some extravasation on the right side here, associated with the hepatic artery. And it's not very clear on this image here, but we can see that there was some gel foam embolization. So with it, there was some hemorrhage from the proper hepatic artery, and the proper hepatic artery and some of the branches of the gastroduodenal artery were embolized. And at that time, the patient was then transferred to a level 1 trauma center. So once the patient was transferred, his vital signs looked like this. He was slightly hypothermic. He was tachycardic to 123. Blood pressure was 159 over 101. Respiratory rate was 38, and he was satting 94%. He was tachypnic, pale. His GCS had somewhat improved. There was a clear deformity on his left clavicle. And now the patient was pre-genetic with a positive FAST. So with this changes in his exam, MTP was activated, ROTEM was ordered, and now we need a plan. What should happen next in this patient?
Dr. Ochman, your comments?
Shoot, it's hard to be only 2 people. Okay, so if you had to explore, I will explore. So this is, I was just thinking about, this is a problem when these things are done in a place where they don't have all the resources, because to embolize the hepatic artery, the whole hepatic artery, is very problematic. In a trauma case, yes, the classical teaching is that you can ligate the hepatic artery, whatever. That, in my personal experience, is not true. If you ligate the hepatic artery in a patient in shock, essentially the liver, or you embolize the segment of the hepatic artery, the portal vein is not enough to supply enough oxygen to the liver, and the liver dies. So I would imagine that this patient now is probably experiencing a significant necrosis of the whole liver, because the whole hepatic artery was embolized. So if I will get this patient here, I would take this patient to the OR, but if I find what I suspect that you found, this is a case I would probably call the transplant surgeons, because I will see if it's possible to revascularize the liver immediately. But this is the reason probably this patient is better dealt at the trauma center, because that decision will have been made before embolization, because now you are having a problem much worse than you had at the very beginning. So I will go to the OR and see what I find, but I'm going to find, I'm pretty sure it's not going to be pretty. Thank you.
Thank you, Dr. Ochman. Dr. Machado, your comments, please.
I agree with Dr. Hoigman. I think this patient needs to go to the OR, and not just because of the liver and knowing liver findings, but with the peritonitis, I suspect that there may have been missed injury, and therefore he requires exploration. Patient is going to shock as well, so he requires significant resuscitation from all aspects, not only from the surgeon, but from the resuscitation standpoint, from a critical care standpoint. So agreed, patient belongs to the OR. Thank you.
Thank you, Dr. Machado. Dr. Supa, your comments, please.
I agree with Dr. Hosman too, not to do the embolization of the proper hepatic artery. You can ligate the common hepatic artery, but not the proper hepatic artery. And in this patient, I think luckily he has perfusion to the right posterior liver. Maybe he has replaced or aberrant right hepatic artery, which we cannot see from the angiography. The other option that the first hospital could have done is to just put the balloon in the hepatic artery and blow the balloon and transfer the patient with the balloon rather than embolizing the whole artery. And I agree with performing laparotomy in this patient because he had obviously peritonitis. And I agree with calling the transplant team to evaluate the patient in terms of reperfusion of the liver. Thank you very much.
Thank you, Dr. Supa. Any other comments? No, we go back to you, Dr. Taveras.
Great. So at this point, patient has been hypertensive and the MTP has been started. Patient's taken then to the operating room and he becomes hypertensive upon laparotomy. So zone 1 revolt is placed while the laparotomy is started, the hematoma is evacuated. Grade 5 liver lacerations is found and the middle hepatic vein avulses. And this avulsion kind of extends into the retrohepatic IVC, extending cephalad towards the heart and the right atrium. The left hepatic artery is completely avulsed as well as the left portal vein, and there's avulsion of the coronary vein. So with this operative findings, what's the operative approach that that's suggested for this case?
Dr. Supa, your comments, please.
I think bleeding control is first priority in this situation, and you can try to do the Pringle maneuver first and see if the bleeding slows down after that. And if you can see the spurters from hepatic artery at the liver raw surface, you can try to individual suture the bleeder. But for the hepatic venous injury, if you can see the bleeding, you can suture it. But if you cannot see it clearly, I think I would start with packing the liver and try to get the patient well resuscitated after performing Pringle maneuver and packing of the liver. And if I could obtain hemostasis, by doing that, I would try to remove the Pringle. And if the bleeding does not go on, I will send the patient to ICU. And embolization may be the good adjunct after the damage control surgery. Thank you.
Thank you, Dr. Supa. Dr. Machado, your comments, please.
So I think the injury has already created the dissection for you. So I would continue with the finger fracture and ligate the middle hepatic artery as is lacerated, and then complete the rest of the dissection, remove the left lobe, pack that area, and then maintain the abdomen open for further resuscitation, packing all sides of whatever's left of the liver. This is going to be a rough ride, I have to say, anticipating major complications and such as further bleeding and bioleak. Thank you.
Thank you, Dr. Machado. Dr. Ochman, Boston.
Well, the inflow of the liver is already compromised by the embolization. So and the Pringle maneuver will not stop the bleeding anyway, because the bleeding now is coming from the IVC. This patient, I will consult the chaplain first, because I think he will be very soon taking over the case. And this is the way to approach this is kind of very counterintuitive, because you have a patient in shock and you have to tell anesthesia not to resuscitate the patient. The ideal scene is to have this patient with a very low CVP. I would put the patient in Trendelenburg to try. So let me backtrack. You need a low CVP to prevent back bleeding from the IVC. So you have to tell anesthesia to aim to a CVP of around 5, which is very, very counterintuitive in a patient who is actively bleeding because they want to resuscitate and get ahead of the game. But what happens when they resuscitate aggressively, the bleeding gets worse and you cannot see anything because all the bleeding is happening in your face. So it's trying to bring the CVP low. However, with the low CVP, the other risk that you are exposed here is air embolism. So I would put this patient in Trendelenburg, trying to have the heart lower than the level where I'm operating, keeping a low CVP, and just go against everything that we always teach in trauma to get proximal and distal control. Just go ahead and try to primary suture the injury in the IVC. Trying to get proximal and distal control, usually you don't have the time. It's very difficult to get proximal or distal control. You can get it just below the liver, but to get proximal control near the heart is very difficult from the abdomen. Most likely than not, you need to do a median sternotomy. You do not have time to do this. The classical atrial caval shunt, it really has been abandoned because when you really have to do that, the patient is probably already dead. So again, I would probably put the patient in Trendelenburg, ask anesthesia not to resuscitate the patient very aggressively and attack the injury directly, suture with underwater, closing the injury in the IVC. Thank you.
Thank you, Dr. Ochman. Dr. Taveras, we go back to you.
Okay, great. So at this point, the patient's being resuscitated. We have gotten the assistance of the hepatobiliary surgeons, and there is some control of the hepatic hemorrhage. The middle hepatic veins ligated, and there's a left hepatectomy that started and partial hepatectomy of the caudate lobe. The diaphragms then opened to get suprahepatic IVC control inside the pericardium. And then that's repaired primarily, and eventually that diaphragm is also repaired. So the left hepatic artery and left portal vein, which were both bowls, were ligated, as well as the coronary vein. Because of the resuscitation and the complexity of the case, there was temporary abdominal closure placed, and at this point the patient has received 12 units of RBCs, 3 packs of platelets, 10 units of FFP, and 3 of cryo. And in the following, we have some representative images. We can see here the liver bed after the left hepatectomy has been performed. After the patient's taken to the ICU for some resuscitation, he eventually comes back to the operating room for a second look. There's an intraoperative ultrasound that happens, and we can see some good portal vein flow to the remaining liver. Cholecystectomy is performed. We do a cholangiogram, and we can tell that there's multiple transected bile ducts. And there's some repair and ligation of some of the leaking intrahepatic bile ducts. And then an omental pedicle flap is placed, and wide drainage. Of course, the drainage is then bilious. So because of concern of the bile leak, patient undergoes an ERCP. That happens the following day. And then we can see that the left side of the intrahepatic tree is a blunt cutoff, consistent with our hepatectomy, but at the same time, we can see there's some stenosis here in the middle third of the common bile duct. Associated with the blunt transection here, we can see some contrast extravasation here. Patient has an plastic stent that's placed in the common bile duct to try to decrease the pressure from the left hepatic duct and to try to relieve this stenotic segment here. Given the patient's coagulopathy, there's no sphincterotomy. And this slide pretty much just describes all that I just mentioned. In the next 48 hours, the patient's LFTs continue to deteriorate, initially from ALT, AST in the 400 to 500s, then they jump to the 3000s. And then his bilirubin goes from 1.2 to 6.4. INR goes to 2.3 despite having FFP, and he starts having significant confusion with an hyperammonemia. So termed to have hepatic encephalopathy, at least grade 2, grade 3. So given this worsening liver failure, what options do we have at this point?
Dr. Machado, would you like to comment?
And Luisa, can you comment also on, so encephalopathy, does he have any head injuries that we're aware of?
No. So initial imaging from the initial, actually the level 4, the first center that the patient was received, there was a CT head was completely normal. GCS initially was 14, then 15. He had a period of clear sensorium and about 48 hours from the last surgery. So this is now post-injury day 4 or 5. When he starts having some confusion and some somnolence.
May I also ask, is the patient making urine, and how are the other organ failures? Does he have a kidney injury?
The creatinine slightly elevated to the around 1.4 to 1.5, but he is making good urine, so he's responsive to resuscitation. However, his sensorium continues to be altered.
Yeah, so obviously the liver injury has caused acute liver failure, and anticipate that the bilirubin is going to continue rising. The liver function tests are going to continue rising. His coagulopathy is going to continue to be worse. This is a time I would suggest consulting our hepatology colleagues and our neurosurgeons, because the next stage in the liver failure and encephalopathy is cerebral edema. So it's probably a patient that requires a bolt to monitor his ICP. And in terms of volume control, and if he's starting to have AKA, consider things like CRRT. Unfortunately, we have to ride the storm. There's no medication or machine, even though there's something called the MARS or the ALAD that is proven evidence-based, that can be used for these situations that have shown a mortality benefit for acute liver failure. With that being said, you can use the MARS, which is almost like liver dialysis for compassionate use, but you have to connect it to the CRT machine in series. So in summary, bolt for ICP monitoring, hepatology consult for consideration of MARS, and connection to CRT. Thank you.
Thank you, Dr. Machado. Dr. Taveras, there is a question in the chat. It says, how long was the first operation taken and performed by only trauma surgeons?
The first surgery was, I was actually about to type the response. The first surgery was performed along with hepatobiliary. Once the extent of the surgery of the injuries was identified, the hepatobiliary surgeons were called for assistance with the hepatectomy and the exposure for the suprahepatic IVC. This surgery was about 4 to 5 hours long.
Thank you, Dr. Taveras. Dr. Ochman, your comments?
Well, I think this patient, the fact that the hepatic artery, the whole hepatic artery was embolized, now you are seeing what, I think this is what you are seeing now. In theory, the portal vein should be able to sustain the liver. However, in trauma, this is not the case, particularly the patient has been in shock. So this appears to be a fulminant liver failure. I don't think there is, I don't think you can write this out. I think this patient is going to die unless he gets a liver transplant. Maybe I'm wrong, but my only consultation at this time will be with the liver transplant team to see if this patient can be, I don't think this can be revascularized, even if revascularized is too late. The fact that the LSTs are rising that way and together with the INR is really very worrisome. I don't think anything can be done except get this patient a new liver. Thank you.
Thank you, Dr. Hoffman. Dr. Supa, your comments, please.
He has remaining right lobe, which is about 60% of total liver volume. So theoretically, he should have enough liver to live, but he has been in bad shock. So the ischemic liver injury is also play part in this situation. And the treatment of the liver failure at this moment is mainly supportive. And I think if the hepatic encephalopathy is worsening, the albumin dialysis or the liver dialysis is useful to try to buy him some time. And meanwhile, we should try to correct some reversible causes like infection or abdominal compartment syndrome, or we should try to do some vascular study of the liver to check for the perfusion of the liver, how is the hepatic artery and the portal venous flow. And also we should check for the outflow of the liver, because sometimes when you try to suture the hepatic vein, you may have occluded the outflow of the remaining liver, which may cause the liver function to be worsened. Thank you very much.
Thank you, Dr. Supa. Any other comments? No, we go back to you, Dr. Taveras.
Right, good. So at the level 1 trauma center, there's no possibility of transplant surgery. However, there's a consultant team and the patient is then sent to our university hospital for transplant evaluation. Once he gets there, his creatinine starts to climb. He gets on CRT. So he gets initially on the transplant list, and then his somnolence kind of improves. There's some issues with his status at that time, so he is delisted, but eventually he comes back to the list with a MELD of 32. This is an exception score because of the trauma burden. So on post-injury day 9, he undergoes an orthotopic liver transplant. So the donor is a 16-year-old male, and he has a cable-sparing hepatectomy. Then the new liver is placed in a piggyback fashion with the right hepatic vein and extending into the vena cava. The supraceliac jump graft is used with the donor iliac artery to provide arterial inflow, and the biliary anastomosis is in duct-to-duct fashion. So in this next image, we can see here, this up here being the head of the bed. And this is how the liver, the remaining liver looked. This is about 9 days from his initial laparotomy. And we can see the areas of necrosis within the remnant liver. Here we can see after the hepatectomy, the extent of the injury and the ischemia. I think Dr. Hoffman mentioned it before, but this is a patient that already had an embolization plus ligation of the left portal vein and ligation of the left hepatic vein, and had the middle vein, the middle hepatic vein that was also ligated. So we had issues with inflow and outflow at the same time. So it kind of explains why this patient had so much significant necrosis of the remaining liver. So on the picture on the right, we can see the donor liver in place, good size match for this patient. And then given the complexity of the wound, the patient was taken back to the ICU with an open abdomen, and eventually goes back for closure of the laparotomy. This patient was seen about 6 months after this transplant, and he was doing well post-op. He was seen by transplant service in the hepatology clinic and had no issues at that time. So this is here the end of the case. So if we have any final comments.
Thank you, Dr. Taveras. Dr. Hochman, your comments, please.
No, it's just one question. He got COVID, so he was not vaccinated after the transplant. That's kind of surprising. I would imagine that they would vaccinate him. But yeah,
He was not vaccinated right away. No, he left the hospital and he was not vaccinated, and he got infected, but he didn't have any issues from it. It was a very mild infection. He got vaccinated afterwards. He had complicated by the fact that he was a little reluctant to get vaccinated, but I think getting infected convinced him.
Okay, because this is kind of like a social comment. Livers are a very limited resource, so it should be given to people who are willing to follow the treatment, not to kind of, because what happens if he's reluctant to take the rejection medication? So it's kind of like the same thing. Is if he, but anyway, so that's kind of like my social comment. But great save, great save. I really this patient most likely than not in any other center would have exsanguinated on the table during the first operation. And congratulations, very good. Thank you.
Thank you, Dr. Hochman. Dr. Machado, your final comments, please.
Oh, fantastic save, Luis. Congratulate you and the team, and thank you for bringing this case to the Tele rounds. It tells you how important it is to have the patient in the adequate center. This patient in a level 2 or a limited resource center would have not survived, and you had all the resources available: transplant team, ICU care, IR, the trauma team, of course, coordinating the care. So that's why we always recommend placing the patient where the resource, where the injuries can be treated adequately. Thank you for bringing this case to our attention.
Thank you, Dr. Machado. Dr. Supa, your final comments.
Thank you very much, Dr. Taveras, for presenting this case to us. I learned a lot, as usual, from this conference. And this is a very impressive result of the patient. In my center, we have a transplant unit, but I have never seen or ever done a transplantation for a trauma patient. So this is very impressive. Thank you very much.
Thank you, Dr. Supa.
Yeah, I just wanted to
Yes.
bring up this paper by Dr. Rivero. I know he's very active with the Pan American Trauma Society. So there's not a whole lot of data on hepatic transplantation after trauma, and he has an interesting series that he has collected, plus the literature review. And overall, it's just describing the demographics and the very high mortality for these patients. So this patient's about a third, even with transplantation, will have a demise. So I think our case was interesting because of the underpinnings of the trauma system and how 3 different hospitals were kind of involved in the management of this patient. So we have all the information from this case. We have submitted for a case report. So this is the reference for all of you, and thank you so much for your time.